next topic for this day is non-invasive ventilation. We have Dr. Vijaya Kumar with us. He is the Chief Anesthesiologist and Director Academic Surya Hospital, Chennai. His interest is in the field of anesthesia, critical care and clinical nutrition. He is acknowledged as the Honorary Anesthesiologist and Critical Care Physician to the Honorable Governor of Tamil Nadu in 2013. He is the President, Tamil Nadu Chapter of Indian Association of Enteral and Parenteral Nutrition. He has conducted many workshops in the areas of critical care, analgesia and parenteral nutrition. He has delivered many lectures both in the national and international forum. He is specialized in tracheostomy and diagnostic and therapeutic bronchoscopy. Over to Dr. Vijay Kumar.
Thank you. Good morning, everybody. So it's my pleasure being in front of you all this morning for this Bridge 2014 program. And I like to thank Dr. Gauri Shankar and its organizing team for giving me this wonderful opportunity to share our experiences with this non-invasive ventilation in a critically ill patient. You all know the intensive care units are nothing but the organ supportive care units. We do support all the organs, and among the organs the respiratory system comes first. When we want to support the respiratory system, the ventilatory support is the mainstay, and artificial ventilatory support is the vital part of the critical care. And in the ventilatory support, we have two arms. One is invasive ventilation and another one is non-invasive ventilation. The invasive ventilation means invading into the airway, into the trachea to connect the patient to the ventilator, then it is called invasive ventilation. If you are not invading into the airway, but you are able to connect the patient to the ventilator, then that mode of ventilatory support is called non-invasive ventilation. And the statistics says 30 to 40% of the patients in critically ill unit, they are ventilated with non-invasive ventilation. And when come to the home ventilated patient, the incidence is very high. 90% of the people in the home ventilation are receiving it through non-invasive ventilation. And when we look into the history of ventilatory support, we can broadly divide into three periods. The first period, actually it started with non-invasive ventilation. As we all know, when the epidemic of poliomyelitis happened in between 1928 and 1952, most of the people ventilated by non-invasive ventilation. With the iron lung, the concept, they will put into the big boxes, they try to create a negative pressure over the thorax and they were able to push the air into the lung non-invasively. So that is the one period, the non-invasive ventilation via negative pressure, and that period is over by 1953. And from 1953 to 1990, it is an invasive ventilation period. All the patients have been invaded into the trachea and connected to the ventilator, and they are ventilated by the invasive mode. Only from 1990, the reappearance of non-invasive ventilation, but not by negative pressure method, by positive pressure method, the non-invasive ventilation has reappeared from 1990, and the developments which we are seeing, it is from 1990 to now. So it's NIV by positive pressure breathing, or combination of these two is the present era of ventilatory support. Not all the patients will be as comfortable as what we are seeing on the right side, left side, having the endotracheal tube, comfortably reading papers on the ventilator. Most of the time, our patients are the invasive ventilation, they used to be sedated stiffly, or otherwise they are receiving some muscle relaxants. So when this is the story, the 20 to 25% of the medications which you are using for the sedation and muscle relaxant, it is only to make the patient to accept the endotracheal tube for the invasive ventilation. So when you are able to avoid the invasion into the trachea with the endotracheal tube, the advantages are many for the non-invasiveness. Coming to the application, when compared with the endotracheal tube, it is easy to implement non-invasive ventilation and easy to remove it also. So intermittently, if you want to give your patient ventilatory support, it is very easy with non-invasive ventilation. And the comfort of the patient is a greater extent. Not having the endotracheal tube passing through the oral cavity into the trachea and accepting it with a stiff sedation into the semi-conscious state, it will not be there in non-invasive ventilation. So really the patient will be definitely a comfortable state, and it reduces the need of sedation in non-invasive ventilation. And the oral pattern is there, so it always allows the patient to have a speech and nice swallowing, and if you want, they can easily cough. Coughing over the endotracheal tube is much discomfort than the coughing without the endotracheal tube, and reduces the need for nasoenteric tubes and esoenteric feedings. And it is also avoid the restrictive work imposed by the endotracheal tube on the respiratory system and the respiratory muscles, and it really avoids the complication of endotracheal intubation. You all know, once you invade into the airway with the endotracheal tube, you can always have a problems while you are extubating them, like a extubation stridor, and they can have a laryngeal edema, and most of the time they will end up in having a tracheostomy. So by avoiding the endotracheal tubes on our patient, we can to a greater extent avoid many complications. Then what are the disadvantages of non-invasive ventilation? The slower correction of gas exchange abnormalities. So invasive ventilation is much more superior when you want a good oxygen transport across the alveolar membrane. That can be very easily achieved with an invasive ventilation, because the airway is totally connected to the ventilator, there won't be any leaks and so. It's increased initial time commitment, and gastric distension is always the problem with a non-invasive ventilation, especially when you are trying to raise the pressure support more than 20, always the esophageal sphincter can get open, and all your ventilations or part of your ventilation can have the potential effect of entering into the stomach and started having a gastric distension. And coming to the interfaces, it's not like an endotracheal tube with a cuff which can occlude the airway totally and get connected to the ventilator. So what are the pressures you are measuring in the airway? It is there on the airway. But when you have a non-invasive ventilation with a mask, because of the air leakage, always the problems. And the transient hypoxemia from accidental removal of the mask, the irritation to the face and especially to the eyes in the medial part, it's more with a non-invasive ventilated mask. And facial skin necrosis, if you put the patient on NIV with the tightly fixed mask for more than 48 hours, the chances of necrosis at the area of pressure is always there with non-invasive ventilation. And the third thing is lack of airway access and protection. If your patient is conscious enough, they can protect the airway from the aspirations. If the patient loses the consciousness in between and having a orofacial mask for the NIV, most of the time when they have a vomit also, they can have a aspiration. And this is a simple system of non-invasive ventilator. This have a one ventilatory unit, it has one blower, it will blow the air, and it will have a pressure regulator. And the pressure regulator will sense the airway pressure and it regulates the blowing nature, and so that the tidal volume delivered to the patient. Usually the circuit is around 6 foot length, and it will have an exhalation port there and it a mask. The mask interface or mask with the connector is there, and the patient can exhale through a hole in the circuit or otherwise in the mask. And this is the NIV devices most commonly used in all the hospitals. There are two devices, one is to deliver the BiPAP and one another is to deliver the CPAP. The CPAP system is very simple. They will be connected to the oxygen source, and that oxygen source will come with a controller here which can control the flow and which can control the FiO2. If you switch over the entire thing to be the oxygen, then your patient will receive FiO2 of 1. And if you control the knob here to control the FiO2, there will be some amount of dilution happening from the atmospheric air. It can dilute the oxygen here, we can reduce the FiO2. If the patient feels suffocation, then you can always reduce the flow here. So it's a very simple, less expensive circuit which can be very easily made in all the hospitals, and this can deliver a PEEP in a spontaneously breathing patient, that is called CPAP. And coming to the BiPAP, we need a small ventilator setup, and this ventilator have a blower again and with a pressure regulator. And these two things which have a scalar form in the waveforms, that can also be connected to the patient. Coming to the circuits of non-invasive ventilation, we have three types of circuits. One is simpler way, what we had seen before. It's a BiPAP machine, and we have a single limb, and we have a mask which can have an exhalation here. This is the intermediate type of ventilator for the home ventilation, where the circuits will be like this with the active exhalation valve here with a single limb. But you can see many invasive ventilators also have non-invasive modes, and when you connect such patients with such type of invasive ventilators with the NIV option, you have to use their double circuits like this. So it is always cumbersome for the patient if you connect them for the NIV in a invasive ventilators, volume ventilators. When you want to avoid the endotracheal tube, then you have to have some devices to connect the patient to the ventilator, and that devices in non-invasive ventilation is called interfaces, and it is equal to that of endotracheal tubes. The interfaces of many types. You have a oral mouthpiece, nasal mask, nasal pillows, oronasal which covers nose and mouth, and full face which covers nose, mouth and eyes, and followed by the helmet. And this is a pictorial demonstration of such interfaces, and this is oronasal mask, and this is the nasal pillows, and this is a helmet, and it's a oral adapter, and this is the one which we commonly use in a BiPAP setup with the oronasal mask, and this is the nasal mask. And this is the one which commonly used is covers the nose and the oral cavity, and it's strapped nicely with the tight fittings so that the patient can be connected to the non-invasive ventilators. And this is the nasal BiPAP or the nasal pillows, and this is one is a helmet where they have an exhalation port here with the positive pressure ventilation over the helmet. And these are the two things, the mask which commonly we use in our hospital. We have a CPAP mask on one side and the BiPAP mask on the other side. And CPAP mask, if you look into that, is a very simple form. You can adjust the PEEP by the valves here. If you want to give the patient of 7.5 millimeter of PEEP, then you have one PEEP valve, and if you want to use 12.5 centimeter H2 of PEEP, then you have another valve. So you can interchange. If you want to increase your PEEP, you can remove this and you can connect it to the patient. So this is a simple mask. It will retard the exhalation. It will blow the air into the patient's lung, and when they want to exhale, it will retard the exhalation, and so that it will give the PEEP, and it is delivered continuously when they are spontaneously breathing. What are the disadvantages of this oronasal mask? There will be fewer leaks when compared to the nasal mask and the oral mouthpiece. The oronasal mask have a very few air leaks and less patient cooperation. Most of the patients are very much comfortable with this type of interface, but the disadvantage is again the vomiting, claustrophobia and pressure sores. What is the big difference between the invasive ventilators and the non-invasive ventilators? If you look into the invasive ventilators, we can call it as a volume ventilators. It's more complicated use because they have a lot of alarms, a lot of settings and airway pressures and other things. But if you look into pressure ventilators like non-invasive ventilators, it's simple to use. And wide range of alarms is not there in pressure ventilators. Constant tidal volume you can deliver with the volume ventilators. But when compared to the non-invasive ventilator, it's a pressure ventilators. You can adjust the pressures. If the airway resistance increases, if you want to achieve the pressure of 25 and 30, it's very difficult with the pressure ventilators or non-invasive ventilation, where you can expect your patient to have a constant tidal volume in invasive ventilators. And without PEEP also you can use volume ventilators, but remember in a NIV you should always use PEEP. You cannot omit PEEP totally and use your non-invasive ventilation. Always either the CPAP or BiPAP, it is with PEEP. Rebreathing is minimized in volume ventilators, but it is always possible in the pressure ventilators in non-invasive ventilation. When they exhale, part of the thing they will again rebreathe, and rebreathing is always possible. Not more than 400 ml of tidal volume in even sophisticated non-invasive ventilators, but we can achieve more in invasive ventilators. So this is the basic differences between these two type of ventilators. And the scalars is very interesting. If you look into that, the simple modes like CPAP and bilevel, if you look into the airway pressures, the CPAP is nothing but a PEEP continuously on a positive spontaneously breathing patient. And if you look into the bilevel or BiPAP, you will have a inspiratory pressure and you will have a expiratory positive airway pressure. There are two levels of positive pressure ventilation in BiPAP. And if you look into the pressure, pleural pressures, the pleural pressure in CPAP is always negative, more negative, but in a BiPAP the pleural pressure is less negative. And the tidal volume you can achieve more with BiPAP, and compared to the BiPAP you can achieve only lesser amount of tidal volume with CPAP. And this side, the scalars, this is the EPAP. The PEEP is given to the patient in bilevel ventilation. If you are giving 5 as a PEEP, the pressure support of 15 will take the PIP to that of 20, and actually what you mean here is pressure support of 10 on the PEEP of 5, so PIP is 15. So this pressure you can achieve to the maximum of 30, and some sophisticated non-invasive ventilators which is appearing in the market can deliver the pressure up to 35. The PIP may be up to 35 also. How to start non-invasive ventilation in our patients? First thing we have to do is the education. We have to tell all the people around the hospital, in the ICU, from the duty doctor to the staff nurses, they should understand what it really means. Plan adequate training for all staff with a calibrated protocol. Then coming to the environment, choose the setting where to start NIV according to the severity of acute respiratory failure. You have to categorize your respiratory failure into mild, moderate and severe, and you should know when to use non-invasive ventilation, which we are going to discuss later on. And coming to the indication, select patients according to likelihood of success. You should not put the non-invasive ventilation when you know very well that they will require a stiff volume support. At that particular situation, you should not try the non-invasive ventilation. And it all depends on your team experiences also. You know very well which of your patients will have a success rate in a non-invasive ventilation in your experience. And availability of intubation. Suppose you know very well that the volume ventilation is more superior than the non-invasive ventilation, but when you don't have the personnel for the intubation, like for an example in a field where you want to transport a patient from the road traffic accident, there instead of going into the invasive ventilation, you can always try a non-invasive ventilation until they reach a place where they can get a intubation. So indications are to be correctly chosen. The information has to be given to the patient very clearly. Unlike the invasive ventilation where you are going to sedate the patient and connect them to the ventilator, in a non-invasive ventilation, it's an information given to the patient, and educating the patient is more important to have a good success, because they will be more cooperative when they have the real idea about the non-invasive ventilation. Coming to the equipments of non-invasive ventilation, choose the correct interface that best fit the facial anatomy. So you should have a wide varieties of face mask in your hospital all the time, so that you have to select the right face mask for your patient. Consider also rotating strategy. The patient may not be comfortable with the same mask for a longer period, and you can rotate the mask or the interfaces with a different interface to enhance the comfort of the patient. Choose a ventilator with a good air leak compensation. There are many non-invasive ventilators available to compensate the air leak. If the pressure is not reaching to the level of 20, which you are set on the non-invasive ventilation, the machine will sense whether there is any air leak in the circuit, so that they will compensate that one. So if you have that type of non-invasive ventilator, better to go for that one to have a good air leak compensation. And all the BiPAP ventilators should have a display of flow, pressure or volume curves, which we had as scalars. The scalars will give an idea how much the patient is getting volume and what is the pressure on the airway on your patients. And how to start the ventilation, how to start the settings on a non-invasive ventilation. Always go for a pressure support. That's a CPAP, and BiPAP is in non-invasive ventilator. With a minimal PEEP to start with, 5 centimeter of H2O is a minimal PEEP is required to start the non-invasive ventilation, and start the PIP at around 15 and slowly increase it at 5 centimeter H2O increments, and if you want you can reach up to 30 to 35 in your non-invasive ventilation. Set adequate FiO2. You should always have an idea how much of FiO2 your patient is getting in non-invasive ventilation. An essential alarm should be set, because if the patient is not getting it properly, the alarm should come, and that should tell you that the patient is not getting adequate pressures or the volume. And tighten the straps of the interface enough to avoid airway leaks, but not too tight. If you tighten it too, the patient will go for a pressure necrosis. If the tightening is less loosened, the patient will go for a airway leaks, and they cannot get an adequate oxygenation. And we have to monitor as usual. When the patient is on non-invasive ventilation, check the clinical status. The more important, you can start the NIV. The washout of the carbon dioxide may not be adequate, so your patient will slowly slip into drowsiness, and they will not have an attempt at all. If the patient is not having any attempt, there is no backup ventilation in the BiPAPs. Very few ventilators having the backup, and that backup also may not be adequate when the patient's airway is collapsing. When the patient is having a tongue fall, the backup ventilation cannot deliver the ventilation as it delivered in invasive ventilators. And prevent skin lesions. Always, every day you should monitor whether the sore is started developing, and when the sore develops, you have to be very careful, give some cushioning effect over the mask, and you can protect the skin from necrosis. And carefully sedate. When the patient is in non-invasive ventilation, you cannot sedate them as you are sedating in invasive ventilators. Coming to the indications, because the success of non-invasive ventilation lies on the indication and also choosing a right people for the non-invasive ventilation. That I like to broadly divide into the evidence-based medicine of NIV. The evidence says we can categorize into high evidence, moderate evidence, and low or absent evidence. We always naturally try to use NIV in a high evidence situations. And coming to the severity of acute respiratory failure, as we discussed earlier, better to divide your patient whether they are not established acute respiratory failure, but with the respiratory diseases like COPD, whether they had entered into mild to moderate or early acute respiratory failure, whether your patient belongs to severe or late respiratory failure. So this categorization is very important when you are going for a non-invasive ventilation, because the goals are different. In a not established respiratory failure, the goal is to prevent respiratory failure. In case of mild to moderate or early acute respiratory failure, the goal of NIV is to avoid intubation on that individuals. When the patient comes with a severe respiratory failure, the goal of NIV is to have a alternate to invasive ventilation. That means you try to avoid invasive ventilation in those situations. So then we can put the indications like this: the COPD with exacerbations, an immunocompromised patient, and acute cardiogenic pulmonary edema. These are the three situations has very high evidence for the success of non-invasive ventilations. When they come with a mild to moderate or a early acute respiratory failure, the indications is very high, and you can choose these patients confidently for your non-invasive ventilation. And in case, if you have weaned them from the ventilator and they are having COPD, in this particular situation, the NIV works very well as per the high evidence. Extubation failures in a high risk patients, especially COPD, post-abdominal surgeries. When the patient underwent a abdominal surgery, most of the time in the supraumbilical area, those people potentially have the tendency to develop post-operative respiratory dysfunction. And these situations, in addition to COPD exacerbations, the evidence having a moderate evidence, but even if the patient is not established acute respiratory failure, if you start a prophylactic NIV, that shows a good improvement on the oxygenation, where you can definitely prevent acute respiratory failure on those individuals. And post-operative period on a lung resection, they are developing an acute respiratory failure, and you are classifying them as a mild to moderate acute respiratory failure, and they also do very well with a NIV, and though the evidence is moderate, you can still try. And for the fiber optic bronchoscopy, when the patient is having a distress, when the patient is having a hypoxemia, where they cannot tolerate the sedation for the good lookout into the bronchus, when you are using fiber optic bronchoscopy on such individuals, the evidence says you can do it with a non-invasive ventilation, so that you can avoid intubations on those individuals. When the patient comes with COPD exacerbations, before pre-intubation, if you want to oxygenate them, then even in a severe acute respiratory failure, NIV can work. Where we don't have evidence or absent evidence, when the patient comes with extubation failures, they develop stridor, and the hypoxemia, acute lung injury, ARDS, and community acquired pneumonia, asthma exacerbations, and do not intubate situation and trauma, the evidences are very less, and it's very difficult to have a success rate when you are choosing the non-invasive ventilation, even though with an idea to avoid intubation on them. And definitely the lack of evidence, and if you want to have an alternate to invasive ventilation in these situations like ARDS, acute lung injury, better to go for an invasive ventilation rather than non-invasive ventilation. So this is a simpler tabular column where we can easily identify where our patient lies, whether they are in this group or this group, so that you can have a success rate of NIV. Since it is a practical pulmonology, I like to discuss some cases where the NIV really works on the individuals. This is a case number 1 where we are going to have a discussion on the COPD with acute exacerbations. The 83-year-old female, and she is a known COPD with the features of carpulmonale and also coronary artery disease, diabetic with a diabetic nephropathy. She used to have home intermittent NIV. She with a BiPAP at home, and frequent admissions in the past with acute exacerbation, and once ventilated and successfully extubated 4 years before, and now she is admitted with a decreased level of consciousness to the intensive care unit. When you do the ABG shows clearly the hypercapnia and hypoxemia, and the decompensation started developing, but stable vitals. So this is the diagnosis. The patient is having a COPD, acute exacerbation, hypercapnic failure. The evidence is very high for the trial NIV on this individual. And she is the lady with a hypercapnic failure. You can see nicely the COPD exacerbation due to the lung infection LRTI, and the patient is in a high PCO2 of 90. She is drowsy, and even if you ask her to open her eyes, she cannot have a fixed eye opening all the time, having a fall back. And this patient is connected to the non-invasive ventilation, where the evidence says we have a higher success rate on a COPD when they are going into the, when they are in the early respiratory failure. And coming to the second case, it is a case of acute cardiogenic pulmonary edema. He is a 53-year-old man with a diabetic cardiomyopathy and nephropathy, admitted with a severe breathlessness to the intensive care unit, and with the FiO2 of 0.8 with the oxygen and mask with a O2 of 10 liters, and he showed a ABG value of pH 7.13. PO2 is 54 and PCO2 48 with lactate of 3.5 and saturation is 70. When you take an X-ray chest of this man, the X-ray chest shows a large pleural effusion on both sides. Hardly able to see the lung volume, only in the apex we are able to see, and he is also having a renal failure of urea of 123, creatinine of 2.6. Though the furosemide has been tried in the ward, he never showed a good improvement in the resolution of pleural effusion, and the pleural effusion is continues to be there. It is a large, and the issues here is whether he needs a ventilatory support. Can we drain the large pleural effusion at one sitting? So this is an X-ray chest of that particular man, a large pleural effusion on both sides, hardly able to see the lungs, and this patient we had put the intracostal drainage with a 10 French cannula. It is not a big ICD tube, and we are able to drain on either side, one side 2.5 liters and another side 2.5 liters, total of 5 liters of fluid under the cover of albumin. We are able to drain it out, and with the CPAP mask. If suppose the non-invasive ventilation is not included on them, by aspirating such a larger volume of pleural effusion on both the sides, you would have gone into the re-expansion pulmonary edema. And when the such amount of severe hypoxemia, we enter into the ICU, we always tend to put the patient on the ventilator before having a trial non-invasive ventilation. So, when you have a non-invasive ventilation where you can choose the PEEP valve like this, if you want to go for a higher PEEP, you can achieve up to 12.5 with a PEEP valve and tightly fixed mask. You can continue the NIV and we are slowly able to drain it out nicely. And this is the adapter which I like to show to you, where we can adjust the FiO2 and also the flow on the CPAP machine. Where it is connected to the oxygen source, you can easily control the FiO2 and the flow on the patient. And he showed a dramatic improvement after a day of CPAP. In the evening, by evening itself, we are able to take out the mask from the CPAP and he was totally comfortable. And this is about a myocardial infarcted patient who develops a pulmonary edema, where they have a very good benefit of non-invasive ventilation. Again, a 52-year-old male admitted with acute infero-posterior wall myocardial infarction with a complete heart block. Temporary pacemaker is inserted and thrombolytic therapy was given, and he got back his rhythm with a normal sinus tachycardia. And the second day, he developed left ventricular failure. PO2 shows 45 and PCO2 is 24 and saturation is 85. Able to cross over the crisis with the CPAP and without intubation and IPPV. Let us see how the CPAP had helped him to tide over the crisis. So, tachycardia in a failure, and even with the CPAP of FiO2 of 1, the patient's saturation is only 95, and with the CPAP the respiratory discomfort, the respiratory distress has come down to drastically with a non-invasive ventilation. So, with the CPAP we are able to maintain him in NIV for 2 days, and the second day slowly started improving and he was able to come out of the crisis without intubation and IPPV. Sorry for the poor video quality. It is nicely demonstrated in a non-invasive ventilation how it helps in a cardiogenic pulmonary edema patient have a good success rate. If you look into the pleural pressure in a pulmonary edema patient, and they are able to generate a negative pressure to the greater extent of 20, minus 20, the pleural pressures are able to jump up with a greater effort of a patient in a pulmonary edema. When they have a higher amount of negative pressure in the pleural cavity, you just see this is the pleural cavity and your left ventricle is here, and negative pressure in the pleural cavity is always try to drag the left ventricle away. So, the after load on the left ventricle increases, and that is why the patient's cardiac output comes down in a pulmonary edema patient. And if you put the patient on CPAP, we were able to bring down the negativity on the pleural pressure to a greater extent. The negative pressure is minimized to that of minus 5 from minus 20. And by applying the CPAP, you can see when the pleural pressure becomes minus 5, the after load on the left ventricle is decreased, so that the effective cardiac output around the aortic valve is there. So, decreasing the effort on the patient with a pulmonary edema by decreasing the negativity and increasing the positivity in intrathoracic pressure, and transmural pressure is nullified. So, that is how the CPAP helps on a patient with a pulmonary edema. And coming to the other situation, the post extubation, you have ventilated the patient and you want to extubate them. To bridge this gap of intubation and re-intubation, let us see the usefulness of non-invasive ventilation. She is 82-year-old female, known case of severe aortic stenosis with a bilateral basal bronchiectasis and COPD. And this lady admitted in ICU with a gasping respiratory attempts. It is an EMD, electromechanical dissociation. We do not know whether it is due to the aortic stenosis or the acute exacerbation of COPD with a hypercapnic respiratory failure entered into the ICU. And after the resuscitation, 5 minutes, she restored the spontaneous circulation after the CPR. An investigation revealed acute anteroseptal MI. severe aortic stenosis and type 2 respiratory failure, hypercapnia, hypoxemia and severe aortic stenosis. And this lady has been ventilated for 4 days, and after the 4th day when she regained the full consciousness and she fit for the extubation, the ABG is like this. She is conscious, but the PaCO2 of 85 and partly compensated. The invasive ventilation for 2 days and extubated, so not for 2 days, it is 4 days, and NIV planned with the goal to prevent re-intubation. And after the extubation, immediately we want to try out the non-invasive ventilation, and the patient is connected to the BiPAP. This is a orofacial mask, strapping it over the face with the tight straps. You have to choose the right orofacial mask, the right interface for the good success of non-invasive ventilation. If your patient is going to have an air leak, then naturally the amount of tidal volume delivered to the patient will be nullified and the success will come down, and naturally they will move into the invasive ventilation with the endotracheal tube. And after the extubation, this lady showed a great improvement with the NIV, and we kept the non-invasive ventilation for 2 days intermittently on the 2nd day, and slowly without ventilation she became all right and went home. And this hemodynamics will tell you how comfortable they are on non-invasive ventilation after the extubation. That to a lady, elderly lady, crossed 80 years with the aortic stenosis and bronchiectasis with COPD. And this is the scalar. You can see on the BiPAP machine, you can easily see how much PEEP we are giving and how much inspiratory pressure they are getting, how much pressure support we are delivering. It's a IPAP is 25 and EPAP is 10. We want to slowly reduce the EPAP and we want to slowly reduce the IPAP also. And you have a nice lock in the BiPAP machines, because the BiPAP, if you are able to set it readings, and that reading cannot be changed by anyone that easily. So they have a lock, and you can, after the setting it, you can lock it and go. And this ventilator also has the backup where the patient stops breathing, apneic, and this will deliver the backup ventilation provided the airway is patent. In an unconscious patient, if the tongue is falling, the backup ventilation will not be that adequate, but if the patient goes for a sleep or the little bit of efforts decreased, this ventilator will take care even the backup ventilation. That is how we can lock the settings. And if it is in the home ventilation, you can also see how many hours this BiPAP is worked on the particular individual. And post-surgical non-invasive ventilation. Being an anesthesiologist, I appreciate the value of non-invasive ventilation in this particular situation. Post-surgical non-invasive ventilation. You all know, to give anesthesia, most of the time we have to invade into the airway with the endotracheal tube, and we used to give muscle relaxants, and end of the surgery or the anesthesia we used to reverse the muscle relaxant effect with a neostigmine. And after the muscle relaxation and the reversal, you can have the problems of recorarization or partial corarization. That means it is not reversed properly, or otherwise after reversal the reappearance of the curar drugs into the bloodstream causing recorarization. Because of these two things, recorarization and partial corarization, they will have a residual muscle paralysis. This is very commonly noticed in a laparoscopic surgical procedure, and addition to that partial corarization, they also have a hypercapnia. When these two things are mixed, the patient will go for a respiratory failure. In those days, we have to intubate them again and put them on the ventilator and extubate them on the next day. But in case if you have a non-invasive ventilator, either the BiPAP or the CPAP, you can easily tide over the crisis. And especially it will be very useful in extubation stridor. When you have an injury to the vocal cord and the cord goes for edema and the patient is having a stridor, immediately after extubation, after the surgical procedure, they can go for a stridor. And to tide over the stridor, we used to give them the hydrocortisone. And to cover up the hydrocortisone effect, for an hour or two of non-invasive ventilation, you can avoid the re-intubation. And coming to the negative pressure pulmonary edema, especially after the nasal surgeries, functional endoscopic sinus surgical procedure, the immediate extubation, the patient can go for a stridor, but they have a very good muscle power because of the adequate reversal of the muscle relaxants. They can generate a higher PEEP, higher negative pressure in the pleural cavity, so that they will go for a pulmonary edema. Once they enter into the negative pressure pulmonary edema, we have to treat them as a pulmonary edema patients for a day or two. But the intubation, again sedation and the muscle relaxants rarely required. The vicious cycle will continues to be there, and it's very difficult to extubate them within 2 or 3 days. So if you try the non-invasive ventilation in that particular situation, you can easily bridge the gap and the patient will get out of the respiratory failure. So this is about the immediate post-operative non-invasive ventilation, and this slide will tell you about the late development. For example, when a patient underwent the upper abdominal surgical procedure, it may be with the epidural analgesia, post-operatively because of the splinting of diaphragm and pushing all the herniated contents in again into the abdominal cavity, the patient can go in for a respiratory failure. That mostly it is a ventilatory failure, the type 2 nature, and those individuals in the second day or third day, when they develop acute respiratory failure, if you give them the non-invasive ventilation, then it is called curative NIV. The same patient, if you don't want them to have an acute respiratory failure, you can prophylactically try non-invasive ventilation, then it is called preventive non-invasive ventilation in a post-operative patients. And the same BiPAP machines, when we are able to wean them out, sometimes we have tried these non-invasive ventilators to extend the ventilatory support in the home also. Patients also have a psychological feeling of improvement because they are taken out from the bigger machine and now they are living with the smaller box ventilators. So this is how, which happened in the first patient we had seen with the COPD exacerbation. We are not able to continue adequate oxygenation. The patient entered into the invasive ventilator with the hypercapnic failure, and we had intubated, ventilated the patient and weaned her from the ventilator with the tracheostomy. And after doing the tracheostomy, with instead of going for a bigger invasive volume ventilators, we used to try the patient on the pressure ventilators like this. The same BiPAP machine connected through the tracheostomy, and with this itself the patient can also get discharged and they can continue to have a non-invasive ventilation, though it is by definition it is invasive ventilation. The extended use of non-invasive ventilators is definitely there, and it prevents more readmissions on such individuals to the hospital. What you require is a circuit, you should have a expiratory port here. So the exhalation used to happen here with the tracheostomy tube, and it is connected to the same BiPAP machine. And as days goes, the patient's relatives themselves can adjust the pressure supports which the patients are comfortable. If the patients are comfortable with IPAP of 20, they leave the patient of 20, and if they are not comfortable, the relatives themselves increase the pressure support. That is how the ventilation at home is continued for a longer period. So if you look into the non-invasive ventilation with the two modes, BiPAP and CPAP, most of the failures are due to the desynchronization between the patient and the ventilator, and it is due to the effort of the patient and the ventilation delivered. It is a mismatch between the supply and the demand of the patient on non-invasive ventilators. So to nullify these efforts, these are the emerging modes in non-invasive ventilator too. It is happening even in invasive side, but they are going to incorporate it into the non-invasive ventilators too. That is called proportional assist ventilation. The ventilator generates pressure in proportion to the patient's effort. If the patient effort is more, the ventilatory support will be more. The aims to improve the patient ventilator synchrony. And this is a neural adjusted ventilatory assistance, that is called NAVA. You have to put a Ryle's tube, and the Ryle's tube have a transducer, and that will sense the diaphragmatic contractions. Once the diaphragm is started contracting, that will tell to the machine to deliver the tidal volume. That is called neurally adjusted ventilatory assistance. And you need a trigger, and the trigger is called electrical activity of diaphragm, EADI. And the EADI is obtained by transesophageal electromyogram mounted on the nasogastric tube. So these are the emerging modes which will increase the comfort of the patient and improves the ventilator and patient synchrony, so that we can even achieve more success with the non-invasive ventilations. So here we are to bridge the gap in between the textbook knowledge and practical utility. I like to conclude this lecture by saying that non-invasive ventilation can bridge the gap between oxygen therapy and invasive ventilation, and extubation and re-intubation. When you are giving oxygen therapy to the patient, if they are not responding, they will move on to the invasive ventilation. And before you are deciding to put them on invasive ventilation, you can always bridge the gap here and have a trial of non-invasive ventilation. And after extubating them from the invasive ventilators, the chances for them to get re-intubated is definitely there. In those situations, in this gap, you can try the non-invasive ventilation. Thank you.
Thank you, sir, for giving us a clear picture about non-invasive ventilation. Are there any questions?
Sir, for this non-invasive ventilation in a patient with COPD with core pulmonary, if at home we are planning to give an NIV, so how do we proceed, sir? I mean, what is the duration? Can it be short duration, long duration, and how long? Can you just shed some light on that, sir?
Yeah, first we have to decide whether the patient will be benefited out of COPD. We are talking about the patient who never entered into the acute respiratory failure. It's not established failure, but they have the disease on the individual. So there is no evidence to say that whether it is helpful or not on those individuals at home BiPAP. But most of the time we have seen that the patients are quite comfortable with BiPAP at home, and they used to adjust themselves, because patient, if they have a consciousness, they can very well choose when they want the BiPAP, when they don't want the ventilatory support. Most of the COPD patients are comfortable at home during the nocturnal BiPAP. They used to put the BiPAP when they are going to sleep, and they used to take the BiPAP when they awake. So nocturnal BiPAP at home is definitely useful, and if you want to use it in the daytime, it all depends on the patient's requirement. If they are feeling some amount of suffocation or they are having some amount of distress developing, they can very well get connected to the BiPAP. Usually when we start the BiPAP, we will advise them to have it for a longer period. So we have to wean them from the BiPAP. We have to cut down the duration of BiPAP therapy on those individuals. It's all trial and error. There is no strict protocols. It's all individualized, and patients themselves can individualize them.
We like to put to our patients how much the unit may cost at home to start.
Now the ventilators are very cheap, doctor. These ventilators cost around 80,000 to 1 lakh. So 80,000, and I like to tell you there are rentals available. If you want to go for a BiPAP machine, the companies are ready to rent it out. So you can have the rental also, and if you want to own this, it is not so costly. When compared to the ICU expenses and hospital expenses, it is around 80 to 85,000 rupees.
Can you kind enough to train us if you come to your institute?
Definitely, I will give you the company's number and you can have a contact with them.
First we will get trained under you and then we will start. Thank you.
You want to have the trial of this NIV? Yeah, you are always welcome, doctor.
Thank you, sir. Thank you. Because it's mostly applied and we require. Actually, we are having patients now. Thank you very much.
Nice.
Thank Dr. Vijay Kumar. On behalf of the Institute Hospital, we would like to give a small token of our love.
Thank you.